Okay, guys, welcome to part 12 of the pharmacology. We'll just start with renal pharmacology. Okay, I think everyone's ready. Everyone sit back, relax, and just enjoy the class. Fine. I think we finished most of the things, most of the explanations which we have done. I think we are very much perfect about it. Right? Thiazides. I think we finished thiazides, right? We finished thiazides. So the final class which we ended up with is metazolam. What is metazolam, right? What we studied about metazolam? Metazolam is effective. This drug, this thiazide is effective when the GFR if the GFR is less than 40. If there is a case where a scenario is like the GFR is decreased, which is less than 40, then obviously you can go for metazolam. This diuretic is effective if there is a low glomerular filtration rates, right? Now we will come with one more drug, that is potassium sparing diuretics. Potassium sparing diuretics. Can you tell me one of the best example of potassium sparing diuretics? That is spironolactone. Spironolactone is very important. You just study the mechanism and the side effects. Mechanism and side effects are important MCQs for INACT as well as NEET. So what is the mechanism of action? What is the mechanism of action? It's simple. It's aldosterone antagonist. Aldosterone antagonist. That's it. What are the uses? Uses drug of choice in cirrhotic edema. Drug of choice in cirrhotic edema. Right? Edema. Then resistance hypertension. Guys, this is very much important point. It's a drug of choice in resistance hypertension. Potassium sparing diuretics are the drug of choice in resistant hypertension as well as cirrhotic edema. Now coming to the next thing, that is amiloride. One more drug, that is amiloride. How the amiloride acts? Amiloride acts by blocking sodium channels. Blocking sodium channels in collecting duct. Collecting duct is the end part of the nephron. So this amiloride acts at the end part of nephron. For example, here it is the collecting duct, right? Collecting ductule. So here in this collecting ductule, this amiloride acts on the sodium channel. It's as simple as that. So important point is, it's the drug of choice in lithium induced diabetes insipidus. Very, very important. It is the drug of choice in lithium induced diabetes insipidus. Then it's also in Liddle syndrome. Liddle syndrome is the drug. Liddle syndrome, the drug is amiloride. Then comes the cystic fibrosis, also amiloride is used. Cystic fibrosis, Liddle syndrome and lithium-induced diabetes insipidus. Now the final group of diuretics is osmotic diuretic. Osmotic diuretics. Can you tell me the famous osmotic diuretics? That is mannitol. Very important. It's mannitol, right? What is the mechanism of action of mannitol? It's simple. It promotes solute free water clearance, water loss. It simply promotes solute free water loss. That's it, as simple. But what are the uses of mannitol? That is important. A, B, C, D, E. Listen this, I won't write. I just simply explain the reasons. In acute congestive glaucoma, this is the drug of choice. Acute congestive glaucoma, this is the drug of choice. Next one is breaking of diuretics, means in resistant, if the condition is resistant for diuretics, then you go for mannitol. Then cerebral edema, then also you go for dialysis disequilibrium. If there is any dialysis imbalance or dialysis disequilibrium, then you give osmotic diuretic. Then finally, expected renal failure. If you suspect that the patient is landing up in renal failure, then always go for mannitol, the osmotic diuretic. but if the patient is not yet landed in renal failure, then only you should give osmotic diuretic, that is mannitol. But if the patient already have a renal failure, if the patient already suffering or already is attacked with renal failure, then mannitol is highly contraindicated in renal failure. Remember this statement, it is a treatment in renal failure, expected renal failure only. Mannitol is given only in expected renal failure, but is contraindicated in already renal failure affected problem. It is contraindicated if the renal failure has already established. Okay. Now we go for one more drug, that is one more class of drug. Those are carbonic anhydrase inhibitors. We already discussed carbonic anhydrase inhibitors. What are those? Carbonic anhydrase inhibitors. We will discuss all the drugs here. What we'll do is we'll discuss all the drugs, what sort of changes come when these drugs are given, we will discuss here. For example, we will take carbonic anhydrase inhibitors, we take loop diuretics, we take thiazides. Just watch this, that's it. You just look into it, that's it. You take potassium sparing diuretics, then finally osmotic, right? So you take these drugs. So we just tabulate all the changes that is brought after giving these drugs. Okay. In ways of potassium, there is hypokalemia. If loop diuretics, thiazides also cause hypokalemia. But potassium sparing diuretics cause hyperkalemia. Why? Because they are potassium sparing. They preserve the potassium, by which they induce hyperkalemia. And also osmotic diuretics sometimes decrease or sometimes increase potassium. Right? You understand what I am able to say? What I want to tell is, you just check the changes that are brought metabologically as well as electrolytes also. You just check these changes, what happens, right? If case of metabolic conditions, it forms metabolic acidosis, but it forms metabolic alkalosis. It forms metabolic acidosis, it forms metabolic alkalosis. These induce metabolic alkalosis, these induce metabolic acidosis. Osmotic diuretics, they cause hypo or hypernatremia. What are the important complications of all these drugs? They cause renal stones. They cause hypomagnesemia. They cause hyperglycemia. They cause increased blood sugar levels. They cause hyperuricemia, increased uric acid. Thiazides cause hypomagnesemia, increased glucose levels. This one is glucose levels. Then they cause increased uric acid levels, that is hyperuricemia. And potassium sparing diuretic, one of the important, I already said potassium sparing diuretics are very important. What is the most important side effect? Gynecomastia. Okay, gynecomastia. Okay, that is the most important side effect. Due to why? Due to spironolactone drug. This is the most important side effect of spironolactone. I already said spironolactone side effects is very important, and it's a MCQ for Neet PG. Remember. Next, it causes hyperammonemia. So that's why it is contraindicated in hepatic or liver disease. Which one? Carbonic anhydrase inhibitors are contraindicated in liver disease because they induce hyperammonemia. Loop diuretics cause hypocalcemia, but thiazides cause hypercalcemia. Okay, and carbonic anhydrase inhibitors, they induce hypersensitivity. Right? I'll just try this. So they may lead to bone marrow suppression. Loop diuretics cause ototoxicity, and they are contraindicated with aminoglycosides. What is the most important side effect of aminoglycosides? What is the most important side effects of streptomycin, kanamycin, tobramycin? What is the most important side effects of aminoglycosides? Can anyone? Ototoxicity. So that's why loop diuretics are highly contraindicated with aminoglycosides. Remember. And thiazides, what they do is, if the patient is suffering with diabetes mellitus, they even more worsen the diabetes mellitus conditions. They also cause hyperglycemia leading to gout. Now, what is the one and only serious effect of osmotic diuretic? That is, it causes pulmonary edema. Very, very dangerous side effect. Mannitol or osmotic diuretics cause pulmonary edema, even though, so you see the logic, even though it is used as, where it is used as drug of choice in where? Drug of choice in cerebral edema, but still it causes pulmonary edema. Very, very important. Thumbs up. So what are other renal drugs? We will discuss some other renal drugs. Right? Some other renal drugs. What are some other renal drugs? We'll write down here. I don't like multiple colors, right? I like only single color. Uses and their side effects. There is something called conivaptan. There are some of the drugs. You just read these drugs, memorize as much as you can, right? But these are very important. Don't think like these are some useless drugs. Conivaptan. What is the conivaptan? It is given IV. That's one important thing, and they are used in SIADH, sudden increase in antidiuretic hormone, SIADH. But I will tell you one thing, right? Conivaptan, tolvaptan, right? Tolvaptan, it's peroral drug. It's mizovaptan, it's also peroral drug. Now, what are these two drugs given for? These two drugs are given as for emergency, right? So actually, this is a peroral drug. But conivaptan is an IV drug. It is generally these vaptans are generally determined as vasopressin antagonists. These drugs are vasopressin antagonists. All vaptans are vasopressin antagonists. Okay, so these vaptans, they are given IV for emergency management of SIADH or long-term management of SIADH. Right? Conivaptan, tolvaptan, misovaptan. Conivaptan is IV, tolvaptan and misovaptan is peroral. So these three drugs, they are indicated in SIADH in case of emergency, or they can also be indicated for long-term treatment of SIADH. Now we come to side effects. If it is case of side effects, tolvaptan mainly causes hypokalemia, and also it causes liver toxicity or hepatotoxicity, right? Maximum duration of tolvaptan is 1 month. That's it. That's the maximum duration. Never cross this duration, otherwise it will lead to liver toxicity, or sometimes it may lead to hypokalemia. Now the next group of drugs is vasopressin analogs. Previously we discussed vasopressin antagonists. Now we will discuss about vasopressin analogs. Vasopressin analogs. Now, what are vasopressin analogs and why do we use them? Okay, what are vasopressin analogs and why do we use them? For example, there is one vasopressin analog called desmopressin. It is generally used as drug of choice for nocturnal aneurysms in children. It is a drug of choice also for central diabetes insipidus. Central diabetes insipidus for nocturnal enuresis, generally seen in children. Then it is also used in von Willebrand's disease type 1 hemophilia A also. It's used in von Willebrand's disease as well as type 1 hemophilia A also. Okay, so these are the uses of desmopressin. Now if you ask me what are the side effects, side effect is very important. It leads to water intoxication as well as headache. That's it, nothing much about it. We go for terlipressin. The terlipressin is important. See, terlipressin drug is important. Why it is important? Because the main use of terlipressin is the drug of choice in acute varicose bleeding. Guys, this is very important statement. Terlipressin is the drug of choice in acute varicose bleeding. A patient of age 19 years old, patient of age 25 years came with a complaint of gastric pain. After undergoing for endoscopy, the doctor, the clinician observed that he is having a acute varicose bleeding. The varices present were ruptured and it's led to severe bleeding. Now what is the drug that you will give at onstop? Forwardly, you will give something called terlipressin. Terlipressin is the drug of choice for acute varicose bleeding. Remember this. Now you come for another vasopressin analog, that is vasopressin itself. Vasopressin is used in where? It's as simple as now. It's used in central diabetes. Same as like that, central diabetes insipidus. Central diabetes insipidus for replacement. For replacement only. Okay. But the drug of choice for central diabetes insipidus is always desmopressin. But if you ask me what is the replacement for the drug, you can give direct vasopressin as a drug also. Okay. And it is also used in acute varicose bleeding. It can also be used in acute varicose bleeding, and it is also used in norepinephrine resistant shock. Norepinephrine resistant shock. Very, very important line. Please give it a triple star mark. Norepinephrine resistant shock. Now if you ask me what are the side effects of this vasopressin, side effects is simple: facial pallor, then you get nausea, vomiting. These are the side effects of vasopressin, right? Now with this we finish renal pharmacology. Now we will come for CNS pharmacology. Guys, sorry if my explanation is not that much good, but if you have any doubt, please feel free to drop it down in the comment section. I will explain each and every doubt of yours, whatever you drop it in the comment section. Please, but just watch the video. It may look like a little bit clumsy, but keep your notes beside. You just go through it, or if you don't have notes, you just write this as it is. Okay? Thank you. Now, drugs for pharmacology, drugs of CNS pharmacology, central nervous system. The first topic is drugs for epilepsy. Drugs for epilepsy. Right? Now, in this thing, what we do is we directly go for the drug of choices. That's it. That's as simple as like that. For example, here we will write the seizure disorders, and here we will write the drug of choice. Right? You take GTCS, you take absence seizures, or you also take Trance syndrome. For all these conditions, the drug of choice is valproate. Absence seizures, it's a repeated questions, guys. Absence seizures is a repeated question. I think I've seen this in 4 papers of INACT previously in the last 7 years. I think 4 years you got absence seizures as a repeated question. So the drug of choice for absence seizures is valproate. GTCS, general tonic-clonic seizures, is valproate. And also is JME, right? Sorry, yes, it's my mistake, wait, it's my mistake. Valproate is the drug of choice for GTCS. It's myoclonic epilepsy. I'm extremely sorry, it's myoclonic seizures or epilepsy. It's also called juvenile myoclonic epilepsy, and Renal syndrome. So the drug of choice is valproate. Now, if the question comes, the patient is suffering with absence seizures, then the typical drug of choice will be ethosexamide. If it is typical absence seizures, if the question was asked like the patient is suffering with typical absence seizures, then it is ethosexamide. But if it is atypical absence seizures, then you go for change in the muscle. For example, what is meant by atypical? Atypical means if there is a change in the muscle tone. If you observe a change in the muscle tone, then it is atypical absence seizures. Then the drug of choice will be valproate, right? And if the patient complains or a patient is suffering with partial seizures or Rolandic epilepsy, then your drug of choice will become carbamazepine. So simple as it is, GTCS, JME, Renal syndrome, valproate. Absence seizures, it's ethosexamide. If it is typical absence seizures, and if it's atypical, you always go for valproate. If it's a partial seizure or Rolandic epilepsy, you go for carbamazepine. It's as simple as like that. No confusion. It's a direct question. Now sometimes you may get a question on Lennox-Gastaut syndrome. The drug of choice is valproate, but you can give other drugs like topiramate, lamotrigine, rufinamide. For Lennox-Gastaut syndrome, drug of choice is valproate. You can give other drugs like topiramate, lamotrigine, and rufinamide. Now, if you see neonatal seizures or seizures in neonates means age less than 28 days. It's called the If there is age less than 7 days, it's early neonate. From 7 days to 28 days, it's late neonatal period. Now, if it's a seizures or neonatal seizures, you go for phenobarbital. Very, very important MCQ for Neet PG. Phenobarbital is the drug of choice in neonatal seizures. Now, alcohol withdrawal seizures. If a patient is a chronic alcoholic, after the withdrawal of the condition led to landing up into seizures, then obviously the drug of choice will be diazepam. And lorazepam can be given if the patient is having some liver dysfunction. So lorazepam is safe in liver dysfunction patients. Okay. Now, if the patient is having status epilepticus, a continuous seizures to a period of 15 to 25 minutes, then the drug of choice will be lorazepam. Status epilepticus, drug of choice will be lorazepam. I will see this MCQ nearly for 3 times in the previous years, right? Now, infantile spasms with tuberous sclerosis, then go for vigabatrin as the drug of choice. Infantile spasms with tuberous sclerosis. Now, if it is infantile spasms without tuberous sclerosis or West syndrome or Salam syndrome, not Salar, it's Salam syndrome, you go for ACTH, adrenocorticotropic hormone. Salam spells West syndrome and infantile spasms without tuberous sclerosis, you go for ACTH. Infantile spasms with tuberous sclerosis, you go for vigabatrin. It's as simple as like, what is the condition if a pregnancy patient or pregnancy individual suffer with epilepsy? It is very much simple. I'll just tell the management, right? For example, if the patient is pregnant with juvenile myoclonic epilepsy and is on valproate, and if the patient is on valproate, you just continue valproate. Don't do any other things. You just continue valproate with therapeutic dose monitoring, TDM, with doing TDM. With this, you also follow folic acid supplementation. Folic acid supplementation, it is a must. Star folic acid supplementation is a must. I will keep it with red box also. Folic acid supplementation is very important. What is the deficiency of folic acid supplementation leads to? What causes due to folic acid supplementation? It's neural tube defects. So remember, folic acid supplementation is must. Plus, right, usual dose, that is how much folic acid you will give? 400 microgram. If history of neural tube defects is there for the mother, for example, the mother is a multigravida, it is her second pregnancy, and the previous pregnancy she has a history of neural tube defects. If there is history of neural tube defects, then give 4000 microgram. Okay. Now drug of choice for epilepsy in pregnancy is levetiracetam. Remember this, very important. Most of the people are writing lorazepam, some are marking the answer, what is that, diazepam. No. Drug of choice for epilepsy in pregnancy is levetiracetam. Remember, it's a silly question, simple question. Some guys are asking, sir, what about lamotrigine? It is superior than lamotrigine. Yes, You can mark the lamotrigine as answer, but if levetiracetam is not in the option, but if levetiracetam is there in the option, obviously it becomes the drug of choice for epilepsy in pregnancy, followed by lamotrigine, right? Now some of the conditions, they may cause teratogenicity in pregnancy. Some drugs, these drugs are highly contraindicated, right? Because there is, for example, you take warfarin, you take phenobarbital, you take sodium valproate. Sodium valproate cause neural tube defects, right? Warfarin cause phocomelia. So these are all things, these teratogenic drugs. So how can you just notify it? Teratogenic drugs you can just classify into least teratogenic and most or potent teratogenic drugs. Least teratogenic drugs, right? I'll just tell you one thing. Just wait. Yes, least teratogenic drugs. If in case of epilepsy, you want to prescribe a least teratogenic drug, then always go for levetiracetam. Right? So if you want the pregnancy patient to be treated for epilepsy, and parallelly you also want it to be least teratogenic, then obviously you go for levetiracetam. As well, if the pregnant woman is having bipolar disorder, one of the least teratogenic drug that can be given is lamotrigine. But if you want to opt for a drug for epilepsy in pregnant patient, even though if it have a maximum or more chances of teratogenicity, but those type of drugs like valproate, if it is needed, you can give. But still, remember, it can also be given to bipolar disorder, but remember it is the most teratogenic drug. Right? Now, we will discuss something about drugs for mood disorders. Drugs for mood disorders, right? Now, what are the drugs you give for mood disorders? What are some disorders regarding mood disorders? Acute mania or mania in pregnancy. What is the drug of choice? Here we will write the drug of choice. Atypical antipsychotics. That is the drug of choice for acute mania or mania in pregnancy. What are those? What is that example? Can anyone tell? Which is the atypical antipsychotic of choice? That is aripiprazole. Rather than typical antipsychotics. Right? Now, if someone asks you what is the prophylaxis for mania, what is the prophylaxis for mania, then you can go for lithium. But if someone asks you bipolar disorder, then also you can go for lithium. But someone asks you rapid cycling bipolar disorder, then the option changes. If it is normal bipolar disorder, you go for lithium treatment, but if it's rapid cycling bipolar disorder, you go for valproate. Okay? Now, if the patient is suffering from depression, severe depression, you go for SSRI as the drug of choice, followed by selective noradrenaline reuptake inhibitor. Remember this? Always drug of choice for depression is SSRI. Drug of choice for depression is SSRI. Always drug of choice for depression is SSRI. Now, if SSRIs are not there, you can go for SNRIs also. SSRI is not there, you can go for SNRI. Right? Now, What if in case if the depression is associated with insomnia? If the patient has depression, also he has insomnia, then the drug of choice will be mirtazapine. But some students are asking, sir, what about bupropion? Bupropion comes after mirtazapine because bupropion is inferior to mirtazapine. So mirtazapine is superior to bupropion because they don't cause ejaculatory dysfunction or erectile dysfunction. They don't cause any erectile dysfunction. Right? Now, if someone asks you depression with erectile dysfunction, what will you give? You give mirtazapine. You give mirtazapine. Erectile dysfunction, you give mirtazapine. Why? Because they don't cause erectile dysfunction. But if mirtazapine is not there, you can answer bupropion. You can take bupropion as the answer because they don't cause any erectile dysfunction. Now, if some patient came with a complaint of suicidal tendency, it is having a suicidal tendency thoughts, then you can give lithium as the drug of choice, clozapine or ECT, electroconvulsive therapy. Right? Suicidal tendency, you can give lithium as drug of choice or clozapine or ECT, electroconvulsive therapy. Now, what are the drugs that cause erectile dysfunction? Why this erectile dysfunction is caused? Because these drugs induce increase in serotonin levels. Now, what are those drugs that cause erectile dysfunction? MAO inhibitors, tricyclic antidepressants, SSRI and SNRI. Right? Now we will discuss about some novel antidepressants. Right? You listen carefully. We will just talk about this novel antidepressants. Now, first one is vilazodone. It is a SSRI plus 5-HT1A agonist. It's a SSRI with 5-HT1A agonist. Okay. Now, if you say one more thing, it is vortioxetine, which is a multiple serotonin agonist and antagonist. MSA. It is what vortioxetine is used for the treatment of resistant or major depression. Very important. Very important. Vortioxetine is used as drug of choice for resistant or major depression. Now we will discuss something about Parkinson's disease. Now, can you tell me why the Parkinson's disease is being observed? Because some of the concepts of CD3, it is due to decrease in DOPA levels. Right? Now, for example, you got a new case of Parkinson's disease. How will you approach? Then what I will do is, I will just simply divide the category into two components. One is, there are negligible complaints. There are nothing much complaints, negligible complaints, and another one are with significant complaints. The patient with negligible complaints, they will not be treated with any drug. But if you ask me, Sir, what if we should, or if we want to give a drug, which drug can be preferred? So the drug of choice, if needed only, actually no drug is needed, but if needed, you can go for the drug of choice, that is MAO-B inhibitors. MAO-B inhibitors, that is salicylate, rasagiline, that one. Or you can also go for amantadine, right? But what are the side effects of it? One is ankle edema, followed by very important side effect, very important. You just remember this, livedo reticularis, very important MCQ. I'll just put 3 stars. Very important. Livedo reticularis is caused due to MAO-B inhibitors. Okay? Livedo reticularis. If you ask me, there are some significant complaints. Now you will just check the age group. Which age are they belonging to? Something like, for example, their age is less than 65. Some people. Some have age more than 65. And age less than 65, these people are being given with D2 agonist. For example, ramiprole, then ropinirole, just 1 minute. If the age is less than 65 years, you give D2 antagonist. Pramipinirole, ropinirole. Pramipinirole and ropinirole, right? Now, if you ask me age greater than equal to 65, age greater than equal to 65, then directly you can go to levodopa plus carbidopa. Levodopa plus carbidopa in case of significant complaints. In a new case of Parkinson's disease, you directly go for neurodopa. Carbidopa and levodopa. Carbidopa and levodopa. Now, here we will just reading about the levodopa, but what are the real side effects of? I think we did not discuss the side effects of pramipinirole and ropinirole. Side effects is fatigue. Side effects is fatigue. But if you ask me some other things with fatigue, then you can say compulsive gambling. Then you can say increased sexual activity. Increased sexual activity. Increased sexual activity. Now up to this we are okay. Now we will discuss some of the side effects of levodopa treatment, and in case if those side effects prevail, what are the treatments and what are the steps that we have to take in order to minimize this condition. Minimize this side effects. We will just look into it. Okay. Now what are the side effects of levodopa? We will write down here. Side effects of levodopa. Now main side effect is psychosis due to D2 stimulation. Okay. Now then what is the drug that you will give? You will give the drug that is pimavanserin. This is the drug you give in psychosis due to D2 receptor stimulation. Psychosis is a contraindication. I just want to tell one thing. Psychosis is a contraindication for the continuity of treatment of levodopa. If the patient is kept on levodopa, he ultimately landed up into psychosis. He got psychosis. Then you should immediately stop the drug and you should change the drug. Rather than levodopa, you can tilt or change to another drug. Right? if the patient have dyskinesia, if the Parkinson's patient have dyskinesia, then the drug of choice is amantadine. If the patient have mydriasis, then it can worsen the glaucoma. And it can lead to some serious complications, and it may also cause one of the mechanism called on or off phenomenon. It may worsen the glaucoma. There is a mydriasis which can worsen the glaucoma. The drug of choice is COMT inhibitors. Entacapone, tolcapone, these are COMT inhibitors. Now, what are the drugs for neurodegenerative disorders? First one is ALS, amyotrophic lateral sclerosis. What is the drug of choice? Drug of choice is riluzole. If not responsive for riluzole, you just give Adora 1. Okay. You can also give some newer agents, but check before giving them. You can also give newer agents, and you can also give sodium butyrate, taurorsodiol. Okay, you can give sodium phenyl butyrate, taurorsodiol, or topharin. I think it's 15 minutes. Shall we stop? We have so many things to complete. Okay, we'll talk about Alzheimer's now. Alzheimer's disease. Alzheimer's disease. What is Alzheimer's disease? Alzheimer's disease is a neurological condition where the patient will have amnestic condition, and you can see that the memory of the patient just gets shattered into fragments or pieces, due to which the patient cannot recognize objects, persons, places, anything. It's a pattern of amnesia, because we have two types of amnesia: anterograde amnesia and retrograde amnesia. Why? Because whether she is trying or mimicking, I don't know, but still Alzheimer's patients, obviously they will be attacked with amnesia. It can be anterograde or retrograde amnesia. Slowly their memory gets fragmented, the pieces get vanished. Slowly they will be going on with they will forget their own family. And that's the problem. And histopathologically, the deposition of a type of proteins called beta amyloid sheets are dropped, or they are just dumped completely in the neural region. So due to increase in these plaques, this beta amyloid sheets, Alzheimer's disease get occurred. Now, what is the drug of choice in Alzheimer's disease? That is the question. It's cholinergic, that is donepezil, rivastigmine, galantamine. Donepezil, rivastigmine, galantamine. And we can also add memantine. What is memantine? NMDA receptor blocker. Right? But this memantine is used mostly in moderate to severe cases. Right? But for mild cases, you can go on with newer agents like Beta amyloid blockers like educamumab, lecanemab. Now, what are some of the drugs for other disorders? I think we'll stop here. Right. In the next class, just prepare what all things I have explained here. Just come in the next class and we meet you in the next class. Bye. Your wise.